describing a robotic bilateral TAPP for bilateral inguinal hernia. This was a 54-year-old gentleman who had pain in the LIF. He was a diabetic, hypertensive, and CT showed bilateral fat-containing direct inguinal hernias. We are using a SSI Mantra system. We used a 3 ports, a 12mm camera was placed about 5 centimeters above the umbilicus, and on either side at the same level, about 8 to 10 centimeters, the two working robotic arms R1 and R3 were placed, and the assistant arm was between the camera and the R3. Please note that the distance from the target area of at least 15 centimeters is advisable. The first look, we'll look at the anatomy of the medial umbilical ligament, which is the urachus, and then the medial umbilical ligaments, obliterated umbilical arteries on either sides, which defines the medial border of the dissection of inguinal hernia. We are now seeing the left-sided inguinal hernia, where you can see the inferior epigastric vessels, which divides the direct and the indirect hernial sacs, and the central area, which is the part of the urinary bladder. At the same time, we look at the area below the iliopubic tract, where we see the vas deferens medially, the iliac vessels in between, and the spermatic vessels on the other side, forming the triangle of doom. And now we are approaching onto the right side of the hernia, where we again see the direct as well as the indirect defects and the inferior epigastric vessels. Again, the vas deferens, spermatic vessels, and the triangle are clearly seen even through the peritoneum. The dissection first starts on the left side from the medial umbilical ligament. As we go towards laterally, we need at least a 5 centimeter cover by the mesh, and that's why the flap has to be raised at least about 4 or 5 centimeters above the area of the defect. The plane that we need to enter is in the retrotransversalis fascia, in between the fascia transversalis and the peritoneum. As we go in, we have to reduce the pseudosac. The direct hernia is first tackled because that's much easier to handle, and once the direct hernia is reduced completely with a gentle traction and counter traction, we enter into the midline pubis or the retropubic area in front of the bladder. And here you can see the obturator vessels getting into vision. The veins are seen. Now the next step is to go and identify and reduce the indirect hernial sac. As you see, we are just lateral to the sac and reducing the indirect inguinal hernia with a combination of blunt and the sharp dissection. Subsequently, as we go down onto the floor on the triangle, we come medially, and the vas deferens is parietalized. It is stripped away from the peritoneal cavity till it turns medially. So this maneuver is important to get a good cover for the mesh to be placed. Laterally, the gonadal vessels are pulled down, and the entire myopectoral orifice with the direct, indirect hernia, obturator foramina, and the femoral foramina are completely dissected. Then the attention is then diverted towards the right side of the hernial defect. Again, the peritoneal flap is raised here. One needs to be just in the pre-peritoneal region, not in the pre-transversalis fascia plane, to cover the nerves and the other structures so that they are not bared laterally. As we go down, again, we'll first encounter the direct hernial sac, which is peeled off. The inferior epigastric vessels, like you can see, is peeled off away. It's gradually between the blunt and the sharp dissection. The pseudosac of the direct hernia is being reduced here, you can see on the right side. And then as we go down medially, that's the pseudosac of the right side being reduced. And then we travel medially in the retropubic region, going down for at least 2 centimeters below the pubis, covering the obturator foramina and also covering the femoral hernia foramina here. Subsequently, the lateral dissection and the inferior dissection is done. The cord, you can see the structures, the vas is parietalized. It is stripped away from the peritoneum till it turns medially. And then the lateral dissection is done, inferior dissection is done so that the mesh lies easily without any curls or wrinkles. Make sure that there is good dissection before the mesh comes into play. Here we are using a 17 by 12 centimeters 3D mesh. You can see here that the contour of this mesh is different for the right and the left side, and it easily fixes. There is a marking for it, that the medial part is being marked, and the mesh is fixed by Ethibond 30 sutures. We prefer to use 3 fixation sutures. We call it a 3-point fixation, the medially and the laterally on the top edges, and then subsequently lower down on the pubic bone we fix the mesh. So with this 3-point fixation, the mesh remains well in place, does not move. Laterally we avoid any fixation to preserve the nerves. Another mesh comes in and again is placed into the foramina. We need to place the mesh in such a way that it will go into the foramina and it will just lie there, and then it has to be regularly placed. Here we are fixing the mesh with the PDS 30 sutures. This has a better visibility than the Ethibond. If you observe, the previous mesh fixation was done with Ethibond, but the visibility of these sutures for knot tying is much better. Of course, you require multiple throws of knots because it's a monofilament suture in contrast to Ethibond. Now we are using the barbed suture. We are closing the defect of the peritoneum with the V-lock 20. This is a 15 centimeter length, so that we'll be using 2 sutures on both the sides. There is another 30 centimeter also available, where with 1 suture you can close both the sides, but that requires much larger lengths, and it's a little bit more difficult to handle in robotic surgery. So here you can see that the peritoneum on the left side is closed with a barbed suture. Finally, we need to close the peritoneum on the right side. That is also done with the V-lock 20. The backhand suturing technique is much easier with the robotic surgery rather than the front-on suturing, but you can do either of the two depending on what you are comfortable with. So these are all 3 arms and 3 port surgeries. We just use 3 instruments, 1 bipolar, a Maryland, 1 needle holder, and 1 Caesar. So that's the final appearance. Both the sides of peritoneal flaps are closed. Post-operatively, patient had a smooth recovery and was discharged. Thank you very much.